So we have about 25 minutes for questions and answers, interactive discussion. Let me start. Skip, you described a nurse navigation system that seems to have improved a whole variety of different patient-centered metrics within the care. So do you view the navigation systems as a destination, or are they a Band-Aid, a transition or a waypoint to some still better system? And if so, what do you think that would look like?
Interesting question. I hadn't really thought about that way. But to me, it feels like with cancer being 200 different diseases, with where we're heading for specialization, that somebody, and for today, I think a nurse navigator, as somebody for that patient to have as a continuity point, at least until they're passed off to whoever's going to be their primary caregiver. We feel good that when you get to the medical oncology office, which is a very nurse-driven situation, that now you have a care quarterback. But I think that's very different than getting through your staging, your workup, and doing that efficiently. So our investment's been the direction, I think that this will be a destination that out in the world of community and practice, and as Susan mentioned, there's Kodiak Island, but in our world, the community can be Kansas City and Austin, not all that small of a town, or Nashville. And that patient getting connected to the possibility of having or being diagnosed with cancer needs that sort of person to be their shepherd through the process.
I should have also mentioned that I believe that Dr. Paz is still on the telephone, so that if any of you have comments or questions of him as well, he's also fair game. Oh, there he is.
Yeah, so quick question. So I really enjoyed those talks, and really I enjoy being able to dream about the impact of the future. But one of my realities is that, again, going back to Southern Illinois and going back to the South Side of Chicago, I have two issues. And I'm trying to figure out how do we grapple with the policies around that. This issue of the broadband is not a little one. As we talk about the future really is dependent on having the baseline fundamental, tools to sort of drive that. And we have a ridiculously uneven distribution of some of those things, including broadband. So one is, what is the policy and how do we go about that? Because what I fear is, example in Chicago, I can go within 5 stops on the L train. That's the sort of train of transportation. And I have a 16-year life expectancy difference, literally within less than a 3-mile radius. And so from where I'm standing, it's not that I don't believe that the technology and the miracle drugs are going to do things. What I'm fearing is that the 16-year gap that I have right now may actually be increased, and that those who have will certainly benefit, but those who have not will not. So I think I'm just trying to grapple with how do we actually deal with that. And then the second thing is, you may not be familiar with burners, but many of the people in my neck of the woods have what are called burners. So they don't really have a cell phone. So Eric Topol once pulled out a phone and said, everything is going to be done on this phone. I go, well, what do you do when you only have a 3-month contract at Cricket? And we don't have everything. So, I'm just trying to grapple with, if the technology is the key and these broadbands, how do we move towards more ability to be able to get this to all people? Sorry to be a pain.
No. Well, I have a piece coming out in NEJM Catalyst in a week or so, and I restate what I just said, which is, I think we have to think about universal broadband as being a key component in healthcare delivery of the future, because it is going to be, which to me means that's why every clinician in America should be advocating for universal broadband, right? It's just that simple. We could do that. We did rural electrification. We did universal phone service. There is nothing that stands in the way of us not having universal broadband except will, right? It's will, it's political will to ensure that it happens. And it doesn't mean the government has to build it. It does mean the government has to require the private sector to build it, if we're not going to have the government build it. But why would we step back from that? As I say, Botswana has a plan to get to universal broadband, okay? And talk about a place that's worried about disparities in care. So I just think we have to start not accepting what is for what could be. And that is very critical. And I also believe the places in the country that need this the most will be the last places to get it unless there is real serious advocacy pushing in this direction. So challenge to all of us just to be more vocal and take this on. And I don't know a lot of clinicians who went to medical school thinking they would grow up to become advocates for universal broadband, but you know what? It's time. It's time.
Well said. Len?
Susan, you got me off my seat. and Len Lichtenfeld, American Cancer Society. And Susan and I did have a conversation last night because I want to emphasize another portion of this broadband issue. There are some of us who do advocate on this. I happen to have the opportunity not only to live in a big city, but have a home in a very rural part of North Georgia. And we have, and people don't look at me like I'm crazy when I say what you just said. People don't realize that the delivery of broadband services in rural parts of this country are virtually nil. We nominally have, and I've actually received a notice from my broadband provider that the max we're going to get is 5 megabits. In Atlanta, I'm getting 100, and that's what my max is. My usual is 0.3. You cannot deliver the kinds of services we're talking about at 0.3. But there's another issue, and actually these were all excellent conversations, and I have a whole long list, and I won't bore you with it because I'm sure other people want to engage in a conversation. But Dr. Burris, one of the things that sort of strikes me, and Susan and I had this conversation last night, when you mentioned again, the magic words for me are, again, finding the patient where they are. And, you think about cancer as a disease. Some cancers, unfortunately, up until recently, we have not been able to do much for. Namely, now we have melanoma. That's already a story that's several years old. But more recently, lung cancer. And blending both what you said, Dr. Burris, and Susan, what you said, there was an article in New England Journal, by the way, that I think did not get much attention, talking about the immunotherapy of primary lung cancer prior to surgery, where 45% of the folks who went to surgery had no tumor, or they had scar left behind, basically, which sort of looks at the future, and again, another conversation. But the question I have is, and Skip, maybe you're the best person to answer, how far downstream do you go with Sarah Cannon? In other words, you mentioned, and you may have already answered it by saying Austin and Kansas City, but what about small towns in South Georgia? I don't know how far this system penetrates, because I think we're going to face a critical need where we sort of said, yes, we can do this here. But now with lung cancer, for example, staging becomes critical. Analytics become critical. There's a big issue with doing appropriate genotyping for patients, because there are still a lot of, believe it or not, docs out there who say, I don't believe in this. And again, you're probably familiar with that. How do we get this downstream where the patients are and deliver that care? Do we envision that everybody going to a center someplace to get hands passed and then back in the community? That's not realistic for some people who can't afford gas to go down the street. So what's been your experience at Sarah Cannon? Because you do have a national footprint. Susan, of course, I'd love to hear your input as well.
That's a wonderful point to bring up. And, as a credit to when the investments were made in Sarah Cannon, it was an early question to say, I know you guys will figure out Dallas and Nashville, but what about Idaho Falls and Wichita, Kansas, which is the next round. So, in your neck of the woods, Rome, Georgia, and Macon, Georgia, those are the next places we need to go to. And those are not that small a community. They're not as even rural as some of the places I won't mention, but we are realizing we have to make that investment. And as much as possible, have the care provided there. Really sort through and a place where, the navigators can help, and this is a part we educate too heavily. You don't want that open chest surgery or that attempted Whipple in many places. So we're going to try to drive that patient into a tertiary type center. But stage 1 colons and early stage breast cancer, where maybe it's not a fellowship trained breast surgeon, but they've been doing it for 25 years and have gotten very good at it, and we've got experience and volume characteristics. That patient probably best served being closest to home. But an excellent point. So we are going to that next round of investments in terms of getting out to that next community that might be closer to 50 to 100,000 population and trying to decide what we can do there. And it's ironic. I talked about rare cancers. To go the math the other direction, we think that we can take care of 60 to 70% of the cancer patients in a community like that they don't need to come to Dallas or to Denver to be treated.
And I would just add, if you think about healthcare, there's a lot of healthcare that obviously requires laying on of hands, but there's an awful lot of healthcare that is just about exchanges of information. And you could probably move a lot of that exchange of information virtually, right? So you keep the laying on of hands, just as you said, Skip, where it needs to happen, but then you take that whole virtual component and you move that as, you basically let the patient be where the patient is and have the information exchanged virtually. Why would we not? That's the way we live our lives in almost every other context nowadays. This is a rare form where we're actually physically present in the same room, except for Hal. So, but exchange of information virtually where it is important and useful for the patient and enables the patient to stay close to home, that's clearly achievable.
So Lee Beamer with the Association of Community Cancer Centers, phenomenal discussion relative to our membership in the community, I think as a synthesis to some of the questions recently asked in your comments, to the points made about molecular tumor boards, next generation sequence report interpretation. We've done several membership surveys in different disease states across the oncology spectrum recently where this concept of just sheer overwhelming emotions of what, as a provider, APP, MD, DO, PharmD, do I do with all of this information? And as a practicing oncology clinical pharmacist until taking the role with ACCC just 3 months ago, I would come in on a Monday morning and easily have 15 next generation sequencing reports on my desk with a physician signature saying, help me. What do I do with all of this? Are there actionable drugs? Who do I give this information to? Is there a clinical trial? I practiced in North Central Iowa. Our closest tertiary referral center was easily, 90 minutes to 2 hours away to the north and the south in Minnesota and Iowa. And with an average age of 72 years, people wanted to stay in their community, and it became very, very important for us to provide those resources. So incorporating future technologies and thinking about clinical care and trying to complex that into the entire spectrum. How do we provide information to the people who need to interpret it for our patients? Do we use patient-facing mobile apps? Do we use biomarker lexicons? Do we use some kind of dedicated programming or curriculum in our nursing and pharmacy and medical school, curriculum across the board? Do you have thoughts? Do people have ideas about or examples of programs that have worked within your own institutions? Because we've got to get that information to rural America.
I'll begin, and maybe, I don't know if Dr. Paz has some thoughts about, how Aetna would view this, and Susan for the access. It's interesting because I went through that quickly and described our concierge service and molecular cancer conferences. And, if you're not an expert in the area, it sounds like, wow, what a big conversation. And so somebody like myself who spent a career in drug development and theoretically would be cutting edge on the clinical side of this, I don't know either most of the time. And yet when I call my molecular biologist, it's what they do. It's like a pathologist or a radiologist reading MRIs. Their answer is in a minute or two. They are familiar with it. They know, Skip, that's relevant, not relevant. Occasionally I need to get back to you, but you're going to that highest level of expertise. And so I do have some confidence that it is scalable, that there's a group of people now that are growing up in this world of molecular oncology that are very expert at this. And it is a place where, thinking back to Susan's comments, crazy for a patient to come in for another visit to discuss that profiling result from rural America when it really could be, and always better if it could be done by Skype or some sort of face experience. But that's another place where you don't often have that information at the consultation, right? And it comes back in 10 to 15 days later. So a great place, but an important point.
And if you think about, as we heard yesterday, Project Echo, what a perfect model that could be. You could essentially have a daily consultation between the what was it, Genospace? The Genospace folks and, everybody else dealing with cancer treatment issues on behalf of a patient in America. You just have to set it up, right? And then figure out how everybody gets paid. The number one question in all of healthcare, right? How does everybody get paid to do that? Well, I think we could probably lick that one, right? We just have to put our minds to it.
If you have any thoughts about how Aetna thinks about investing in sort of, or helping or thinking about reimbursement there?
Yeah, I would say two things. So this is really a subset of a larger question around genetic testing in general, and this is something that comes up frequently. And I'm asked to speak at precision medicine conferences not infrequently to really address this issue. So one is the appropriate use of testing, molecular testing, in one form or another. And it is interesting to see that there are huge opportunities around educating physicians and other clinicians around the appropriate use of tests. And then the second piece is reimbursement and how do you pay for that? And clearly, as I alluded to yesterday, the way you do that is based on the evidence. If there's good clinical research evidence to support the use of testing and its coverage, excuse me, it should be. It makes great sense. But I think this is, a larger piece around all the information that is now available, and then how do we pay for it? And this gets back to be it molecular testing or telehealth. Things get a lot simpler when we move away from fee-for-service and we move much more towards value-based reimbursement, because then all of a sudden, all this, all the nuanced rules around what's covered and what isn't covered start to, go into the background, and it's really about what makes the most sense, and shouldn't it be the person who is writing the orders making those decisions with the patient, knowing that what makes the most sense is what's going to improve someone's, outcomes, and then they have the dollars to make those decisions with, as opposed to a system today that focuses on reimbursement for volumes of services as opposed to the value in those services.
Thank you all.
Hi, Sam Takvorian from the University of Pennsylvania. Thank you to the panelists. This was a really terrific, very forward-thinking panel. Dr. Paz, my question is directed at you, and thinking both about where we are now, or where Aetna is now, and where it is looking to be in the future. So you discussed the oncology medical home, a move towards value-based payment as being an important enabler of some of the innovations that were discussed at the organizational level. And I wonder what the quality metrics are that you're holding your practices to account are now. Are they simply adherence to pathways into processes? Are you thinking about outcomes, and what might they look like in the future?
Yeah, and I think this is, as I mentioned earlier, this is something in evolution. Right now, our focus is on the pathways, and certainly there are other elements. We ask that in these practices that the patients have an opportunity to complete satisfaction surveys, to look at their perception of the care they're receiving, and certainly including nurse navigators and the use of decision support tools and electronic medical records, all part of it. But I think there's enormous opportunity to continue to evolve this. We have a project that I know Susan is familiar with, and Len is as well, called Aetna Care, that we launched. We're going on 2.5 years now in New Jersey. We're now scaling this clinical strategy nationally, and we started with diabetes. So just to give you an example, and in that case, we have nurses that literally go in the homes of patients that are medically complex, have chronic illness. Keep in mind that that individuals in our commercial plans with chronic illness, it's a single-digit percent of the population that attributes to about 50% of our overall spend. It's about 2 or 3%, and then in Medicare, it's about 8 or 9%. So huge opportunities to address not only the cost of care, but most importantly, the results that are achieved. So these nurses go in the home. Through physician coaches, they follow evidence-based approaches, and they partner with physicians, primary care physicians in ACOs in the community. And they bring into the home an ecosystem of solutions. They have a telehealth platform they can use that includes digital stethoscopes and otoscopes, so on and so forth, that the physician can access from their office. And then those various solutions include partnerships with pharmaceutical companies around value-based contracts for their drugs and the outcomes around their drugs, device companies, and we even wind up partnering with supermarket chains that have certified nutritionists that walk the patients up and down the supermarket aisles, educating those patients around healthy diet and the appropriate steps they can take. But the nurse is in the home, meeting with the patient face-to-face. We employ the nurse, but the nurse partners with the physician in practice because we believe the role of that individual as a navigator, but also as an interface, so that we're not just depending on the phone app that we offer or the telehealth solution, but really it's that driving care into the home, the right care at the right time, the right place, really can achieve the value. And ultimately, many of these individuals, are on high deductible plans, so they have huge financial risk. Their employers have huge financial risk. But ultimately, we think it's important that all of us in the ecosystem, the physicians, pharma, device companies, so on and so forth, are sharing in those outcomes as well. And that's where, speaking personally, I would like to see this continue to evolve. I believe it's eminently doable. I think we've shown clearly in terms of the outcomes we've achieved in New Jersey as trend, and we're still collecting data to get p-values of statistical significance. But as trends, we're seeing the results of these initiatives already.
Thank you.
Hi, Hildy Dillon from the Cancer Support Community. I would just like to hear from each of you with each of the models that Susan, you're proposing and what's happening at Sarah Ken and how it's happening with this program, the oncology medical homes. How are you incorporating psychosocial support for patients into these models, and through what type of licensure and professionals are providing that type of care specifically for oncology patients and their caregivers?
Well, I think that's a wonderful question, and it's part of what you would have to take up as you thought through a workforce strategy, right? Exactly those questions. Who does that? What level of licensure? I'll just make another pitch for technology. Not that I think technology can replace everything, but we already see some amazing results on phone-enabled cognitive behavioral therapy for people. Now, doesn't mean that that's a substitute for human beings, but could it be an adjunct?
There's a skill and training to do that. So that's why I'm asking the question.
No question about it. No question about it. But yes, thinking through exactly. Look on the PCORI website for a analysis of a technology called Focus for use with people with essentially severe and persistent mental illness, schizophrenia in particular. I mean, they are getting enormous results from those kinds of technologies as an adjunct to having a relationship with a clinician. Yeah. So thinking through exactly how to calibrate that and what level of person, what about, periodicity of physical visits versus supplemental visits that are virtual, et cetera. I just think it's really open terrain to begin to explore, but I think there's some really exciting potential.
I'll just add real quick before Dr. Paz speaks. Similar strategies, trying to, where we can, incorporate a telemedicine Skype sort of service into that. We also find that we're needing to break it into buckets. We have an Ask Sarah program to have calls come in and filter. And sometimes that psychosocial support is very much wrapped around financial concerns. So we've got a different group of financial counselors that we're rolling out. Some of those folks really need to get tied into our palliative care program. And then there is the true, need for a psychologist sort of bit. So an excellent point, and we have found it to be the most difficult part of the care experience to help with, and are open to suggestions, but it is clearly a bit of a mountain to climb.
Yeah, that's a really terrific question, and I'm glad you asked. So in some of the areas that we're engaged, so for example, in our Aetna Compassionate Care Program, which is an end-of-life care program, that is our nurses are engaged in that work, again, working with groups in the community. In our initiative around the opioid epidemic, we again have a nurse who is involved in that kind of work. But in the case of our oncology medical homes, we leave that to the providers, to the oncology homes that we work with, to engage in those kind of solutions. But without a doubt, I think it's exceptionally important part of the entire care process.
Okay, well, thank you very much. We've come to the end of the time for this session. So there's a break. There should be coffee and snacks outside, and we'll reconvene at 9:45.